Turn it over to Mayana.
Sorry, Mayana, your turn. That's me.
It's good not to record me. I agree with that.
Well, thank you. Yeah, and thank you, Jim, for just like that really wonderful recap. I think it's always really helpful to like hear that, especially if anyone's new here. So yeah, with that, I would like to introduce Terry Lee. Terry Lee is a senior behavioral health medical director for Community Health Plan of Washington. He's a psychiatrist with extensive experience working with adolescents and families with complex behavioral health needs. And Terry often, oh, sorry. Yeah, and Terry also, yeah, works with those often involved in multiple child serving systems, such as foster care, the legal system, and behavioral health. And today, Terry will be discussing child serving systems of care and transition age youth services. So with that, yeah, take it away. Thank you.
Well, thanks, Mayana, and thank you to Sarah and Jim for inviting me to come and meet with your folks today. I've not really met with this group. I guess we had some other meeting, but I don't really know who's in the audience here. And in talking to Sarah and Jim, I'm not sure what I can speak about. I made some slides, but I don't know if you want to hear about, what my ideas. I could actually probably learn from most of the people in this audience. And
Terry, we definitely want to hear about your ideas and see your slides. So we would love to hear what you have to say. And again, this is, as Ms. Nicole wrote in saying, we'd love to hear. You have great insight. And part of this, which Jim did say, is doing the presentations and strengthening knowledge and bringing us all together to kind of have these conversations. We also have a number of young people with lived experience on this meeting. So I think whatever you have to say will be of great interest.
Okay. Well, I do want this, again, to meet the needs of the people here. And, I want it to be a discussion. Again, I made some slides, but we can stop at any point and talk about them. And I'll stop and talk about them. So, all right, I'll start then with my slides. So I don't use WebEx that much, but let's see if I can find the right one here. Okay, can you see this?
Not yet. You probably have to share your screen. And you can send it to me and I'm happy to share mine.
Sure. Let's see. Okay, maybe now it's working.
Yes.
Okay, great. So let's see. All right, so this may be, I don't know if people can see this or not, but this is an old study that was done. There's an old term called social emotional disturbance. Again, a word for, a term for kids with high behavioral health needs. So this was an old study, but I like it because it looked in Washington State. And again, I don't know if you can see the stuff on the bottom, but can you see my pointer? Yeah, so this blue line, well, first, this percent of kids qualifying as having high behavioral health needs. And then these are the different child serving systems of care, state, some of them are state agencies. Again, these are the old terms. So there's child welfare, children's administration. The old term was DCFS, used to be called Children's Administration. And then this one is juvenile rehabilitation, JRA, the juvenile legal system. Sometimes I'll say juvenile justice, but of course the justice system is not, or the legal system is not just, but I've kind of been around a while. So sometimes I use that term, but it's really a legal system that is not very just. And then this is developmental disabilities, mental health. So this is DBHR or anyways, the mental health division. This is special education over here. And this is regular education. So in case you, so the part of the point of this slide is to show that kids in these different child serving systems have high behavioral health needs. And you may enter through one door, but really, if you're involved with one system, you're likely to have behavioral health needs. Your family is likely to have, would likely want to seek help for a youth's behavioral health needs. But it may not be through the mental health, services. The other thing to know is that kids involved with one system are likely to be involved with multiple systems. And so I've spent a lot of time, again, working in these different systems, both like, I was consultant to the foster care assessment program, which some of you may be familiar with. It's a state program, and it, again, it's shrunk from what it was, but they used to have like a mental health consultant or a psychiatrist, a psychologist, pediatrician, social worker, cultural expert that would consult with children's administration, child welfare workers in our state, and help with the case that was presented, but not just help, but then follow the kid 6 months out. So it's not just you're giving recommendations one time, but to kind of follow up if the recommendations couldn't if there were problems. Then I've worked in the mental health system, again, high needs, so like Child Study and Treatment Center. And then I'm going to talk about a program. If we want, we can talk about a program that I work in both in our state as well as other states and even other countries. That's community-based, so where kids can stay at home with their families and be treated there rather than have to go somewhere else for treatment. And then I've worked a lot in juvenile rehabilitation, both King County Juvenile Court, King County Juvenile Probation, King County Detention, Echo Glen Children's Center, and then transition programs.
I'm covered up.
Looks like Sahara and Josh. Yeah, okay.
Yeah, I'm just gonna say if everybody can go ahead and mute themselves, but we're so happy you're here.
Sorry about that.
Nope, you're good.
Okay. Folks can still see the slides because Sarah came on. Okay, so and just to give you some idea again of how people can be multiply involved. So Annie or the MacArthur Foundation, I believe it's the MacArthur Foundation, funded a study at King County Juvenile Court, and they looked at all the kids who came through one year. And the interest here was what is sometimes called dual system involved, or crossover youth, that is youth involved with the juvenile legal system and child welfare, and using a definition of child welfare involvement that ranged from someone called CPS on a kid and CPS chose not to open a case, or to be a state dependent, that is parental rights have been terminated and the state or the court now oversees things for the young person. Using that range, about 2/3 of the kids that came before King County Juvenile Court had prior child welfare involvement. And then looking at Echo Glen, just again, taking a snapshot, I'm sure the numbers are much higher now, but this was a while ago. About 40% of the kids admitted to Echo Glen, which again is a juvenile, it's long-term secured event detention. People have been adjudicated there by a judge to, it's like the prison for kids, essentially. About almost half the kids had an IEP that is qualified for special education, and about the same percent of kids had less than a 5th grade reading level at the time they entered Echo Glen. Now, there could be multiple reasons for that, and there are high rates of learning disorders and other things that interfere with learning, but there are also, people are probably aware that kids, say in child welfare, foster care, they just by being placed and moved, that disrupts a lot of things in your life, including your education. They say like each time you change schools, you lose about 4 to 6 months of learning because the curricula never line up. And so you might be ahead in some things or behind in some things, but then with multiple moves, then you tend to not be caught up on any part of school. So again, all these are very high risk for transition into adulthood. The other point of this slide is that that in the United States, and especially, I've done some work in other states, but I do think it's a little worse in Washington State. There's a lot of siloing of services. So people may be aware that, like in these different child serving systems, So mental health, child welfare, juvenile legal, special education, that you're actually eligible for other services that aren't eligible to other kids on Medicaid. So if you're an advocate, if you actually understand how these systems work and you understand like the rules or regulations governing them, you can actually, be a good advocate. The other problem with that, though, is that then there are certain people that have benefits that really could benefit everyone. So like when it comes to transition, again, folks here are probably aware of, the feds made available extended foster care. It varies state by state, but that really only applies to kids who are in the child welfare system. And again, states can do it different ways. And our state is kind of, well, I haven't looked at this recently, but the last time it was fairly restrictive in the sense that you had to be like in foster care on your 18th birthday. Maybe that's changed. Has that changed? Like some places, like if you had ever been in foster care, you might be eligible. Just using that example, though, in other places, other countries, again, more like Northern European or, so like the Scandinavian countries or Australia, New Zealand, that they help families that just need help. Okay, so you don't have to be like in foster care or at risk for going into foster care or at risk for being, being court involved. That the families can just come forward and say, we need help. And the same with transition age youth, so youth like between 18 and 25, that there are just more supports. And housing, again, just using my example of other states, I've been involved with high intensity services in other places. And, so again, in I do some consulting in Melbourne, Australia. I've done consulting in Norway. Like homelessness just isn't an issue for most people. like it's very rare. And even in say New York City, it's even much less than in Washington State. That we have these teams again that have been disseminated to other states, but also in our state. And our therapists, whether they're in King County, Snohomish County, Kitsap, Pierce, Tri-Cities, Yakima. The therapists that we have in Washington State spend a lot more time looking for housing for families than in other places. So again, just to give that perspective. And so, yeah, I certainly appreciate like, what you all are working on, because there's such a need in our state for housing for transition age youth. And so I see Shannon put something on, you have to be dependent on your, so that's the way Shannon Quinn wrote, you have to be dependent on your 18th birthday to access extended foster care. So again, it doesn't, like that's the way we set it up in Washington State, but states have the option of being more generous and than that. And the same, the feds fund extended foster care to age 21, but some states actually choose to fund beyond age 21 using state funds, not federal funds. So again, there are a lot of policy things that could be called into to help. Again, I don't know, people want to discuss anything I've said, or should I just keep going? I guess I'll just keep going.
Well, I have a question for you, and if you're going to
Yeah.
cover it later, please do. But in the spirit of making this interactive and encourage others to ask. So, and again, this is going to be more your kind of professional experience as much as anything. But one of the things I've seen over the years in my role as a clinician and hear from other people is sometimes it's really hard to tell how much of what we're seeing in an adolescent or a young adult by way of behaviors, and particularly behaviors that some might say, oh, that's not very healthy or good for you, it's hard to tell how much of that they came into the system with, or as a result of surviving the very system that was supposed to help them, whether that's quite frankly, foster care, juvenile justice, and even inpatient. We're hearing how young people are treated when they went into treatment, shamed and blamed. Just love to hear any thoughts you have on that as a longtime clinician.
Oh, great. Yeah, I mean, I could talk about that for a while, but yeah, I agree. Well, first, I would say that the kids, again, they're kids that can be identified early in life, but before the age of 5, that just face a lot of adversity. So we talk about social drivers and things like that. And, absolutely, if your parents are having problems, like poverty itself is a risk factor, right? And then, if your parents themselves don't have stable housing, if your parents, have behavioral health needs and behavioral health needs that aren't being met, that's going to really put you at increased risk for having your own needs. But then, yeah, there's a lot of other evidence that you're pointing out, Jim, that yeah, just being pulled out of your home by, again, this is the job of child welfare to protect youth. But again, if there could just be more support for the families, again, with if the parents are having housing problems or behavioral health problems or financial problems, you could avoid the trauma of removing a kid. And then we used to have more kids in foster care, but there was some look at, like, is the foster home any better than the home that the kid is being pulled from? That there were some, there are kids, and this happens all the time. I'm not trying to blame anyone. I'm just saying it's kind of hard to find enough homes for kids. I mean, people may be aware there's a class action lawsuit now, and there have been a couple against the child welfare system. So this is for kids being kept in hotel rooms, right? So I mean, there just aren't enough good homes such that kids are staying in hotel rooms. I talked about the negative effects on education from being moved around. Kids have been abused in foster homes. So all these can be bad. We actually have a fairly progressive juvenile system, compared to other states. But it's not where you'd want to raise your kid, unless it was an extreme case.
MJ, I think MJ had their hand up, so I just want to watch hands.
Yeah,
and then
I saw someone had their hand up. Yeah, MJ.
Yeah, so I was just curious, like, what the class action lawsuit is called, and also, you said that you were a part of a program, but you didn't necessarily go into like what the program was. That was like a community-based program. So I just wanted to explore, what those were.
Okay. Yeah, I have some slides, so I'll talk about that if people want to hear about it. The current lawsuit is, again, folks in the audience may have a better idea. DS is the current lawsuit, and prior to and in my professional life in Washington, that's the second class action lawsuit. BRAAM, BRAAM, was the first, and then there are individual civil cases that so each year, it's not all a bunch of kids, but like something bad happened to an individual kid, and looking into that, there are millions of dollars each year that are paid out for individual civil cases. So you can also, again, if you're looking at this from a policy standpoint, then could you take these dollars and do a better job? So like, how much is it? I think I said I used to work at Child Study Treatment Center. Jim came out there many years ago, kind of looked at what we're doing. Again, this is old. These are old numbers, but like, again, as of years ago, it costs about $300,000 a year to have a kid at CSTC for a year. It costs over $100,000 a year to have a kid in the juvenile legal system, like JRA. So once you start looking into these costs, you think, couldn't we do something better? And in other states, actually, the juvenile legal system costs even more, upwards of $200,000 to $300,000 a year to lock kids up long term. So again, I'm kind of rambling, I know, but
I have a question
sure.
regarding that. Just interested in, are there any states, in the domestic? I love international policy as well, but who's doing it a little bit better? with the cost savings, and how are they allocating those funds that actually offer maybe behavioral health support? Because I'm
Yeah.
seeing this trend, and this is a conversation we've been having with some coalition members, is like the lack of behavioral health solutions for system involved youth. And so that's kind of my question and interest.
Yeah. So I haven't taken a close look at the state, but New Jersey has been presenting a lot of information on how they reformed their system, and they're saying everything was changed. You know, so it isn't one thing, but they do place a lot of. So Liz Manley is someone that I know our state has been consulting with, and I've talked to her at meetings, and others have really described the work. That there's not one paper that describes what they did, but and she would say they changed everything, but what was important was what they call mobile outreach. So I mean, they have mobile crisis outreach, but just mobile outreach, meaning if a family needs help, then they go out and try to provide help. And it doesn't have to be a crisis. And then by being responsive to that and then kind of following that, like, well, once you determine their needs, what does the family need? And then trying to address those needs. And then trying to make, like, say, the mental health and child welfare and legal systems more responsive and move more upstream. They've been able to, like, close a lot of residential programs and juvenile, long-term juvenile detention programs, things like that. So they have, again, there's not one paper kind of summarizing everything, but they have all sorts of metrics showing that you're getting more outpatient treatment and you're getting less deep end treatment, if that makes sense. So sometimes people talk about a pyramid of need, kind of prevention, like there's more primary prevention and secondary prevention and less tertiary services that are being delivered. I would say also Connecticut and Massachusetts, again, two fairly wealthy states, two fairly progressive states, also put more into their systems and turn more, I think, to progressive policies and again, more earlier intervention, more evidence-based practices, things like that. More support just in general, if you look at like how much is spent on each youth or like what are the programs provided to transition age youth. Okay, all right. Someone keep track of the time, so let's see. Sorry, so this is a busy slide. I won't, I guess for the sake of time. Multisystemic therapy, I guess I don't have it here, but the slide before had to do with cost savings. So the Washington State Institute for Public Policy, folks might be familiar, but they advise the legislature, they do cost benefit analyses, looking at the costs of interventions and savings or cost to crime victims or actually citizens. But for the legal system, they look at the cost to legal. I guess I'll go back to the slide, sorry. Confusing slide, but this is looking at the cost to crime victims and taxpayers. So this isn't savings to the healthcare system, but to citizens and crime victims. So the idea here is to be on the right, meaning these are cost savings, and then on the left, meaning they cost the system money. Again, it's kind of small, I can share this. So here, multisystemic therapy, MST is a program that I work in, that's the program I was referring to, MJ, where WISP determined that for each kid who goes into MST, that this is not just Washington State data, but national data, it saves the system about $40,000 to $80,000, and that includes like treatment failures and the cost of treatment. And so the calculations here are things like what's the cost to a crime victim if they were hurt and they have to get medical care, they have to take time off from work and get physical therapy, or they have to get treatment for PTSD, or there was damage to their home. What are those costs? as well as what's the cost of having like a a court system, the judges, the attorneys, the public defenders, the prosecutors, juvenile detention, again, the cost of long-term detention, like I said, about $300,000 a year. What are those costs? And so that's how they determine the cost savings. So the three, well, the four, and the state has pursued some of these, some better than others. The things that seem to work, these are intensive services, functional family therapy, multisystemic therapy, treatment foster care, which is not just any kind of foster care, but treatment foster care Oregon. It used to be called multidimensional treatment foster care. And so the state has tried to implement some of these things, again, some better than others. Aggression replacement training, which is not a treatment, but an education. So the state pursued these four. Again, this is going back. And then these are things that cost money, like Scared Straight. You know, it's a TV show. Don't have time to talk about it a lot, but that that actually costs money. Again, we could talk about. In other words, that increases the likelihood that a kid is going to commit more crime or be arrested in the future. So multisystemic therapy, this is what I do. What is it? It's intensive, community-based. So intensive means like each therapist has like 4 to 6 families that they work with. That's like a full-time therapist position. So pretty low caseloads, lower really than anything else that we do. Again, cost-effective, time-limited. So this is something folks don't always think about, but that's part of what makes it cost-effective is that what MST is, it's a family intervention at its heart. We work with kids, but we try to increase the skills of the parents to manage their kid. It doesn't, you don't have to be there for years. You know, most families will get it. You know, we try to increase social supports to the family as well as the kid, you know, using their natural supports. So again, not counting on professional supports long-term. And there's a heavy, so again, the focus is on caregivers and parents, and there's heavy emphasis on family voice and values. And so by learning about the culture of the family, you are being culturally responsive. Again, I have some data. I don't know if we're going to get to that. There's a lot of quality assurance measures. So again, there's a lot of supervision. There's like 2 to 3 hours of supervision to the therapist every week. And then some of the quality assurance, and then there are a lot of trainings, but there's also fidelity monitoring. So once a month, someone not involved with the treatment calls the parents, and there's a structured instrument that goes through and says, do you think your therapist understands what your family needs? Is your therapist helping you to achieve your goals? So there's an instrument with 26 questions like that. And based on that, based on the responses that the family gives, we can actually, there's research showing that there's a score that it's called the therapist adherence measure. And that score has been shown to correlate with outcomes. In other words, if you're more adherent, the outcomes are better.
Dr. Lee, we have a question in the chat. Sarah, Shannon, can you come off and ask your question, please?
Yeah. So, so the organizations, so again, this is where some of the siloing comes in. So for mental health, it's available in Thurston County. And so all the MCOs cover it there. Then in Greater Columbia, I'm using the regions that, the Healthcare Authority and other places use. So comprehensive has a team situated in Yakima, but they do cover, the region around Yakima, and another team in the Tri-Cities. And then, again, this is the siloing. So for years, I worked with a team for the court, and you had to be court involved. And so Therapeutic Health Services in King County still runs a team, but you have to be court involved to be able to get the service, which again, it's not great policy. And then the last I heard that they were actually expanding Snohomish County juvenile court was also wanting an MST team for their court-involved youth.
Scott from the MCOs has also added into chat to that. I'm going to encourage people to raise hand and talk. I know we like to chat. Dr. Lee, I'm going to say something, and then I'm going to ask some more questions about MST. I had the opportunity to work with Dr. Trupin in MST through the Odessa Brown Clinic years ago, and found it to be an interesting model. I'm going to say something now that I mean with all due respect, but just us folks sort of, if you could, at best you can, replace kid with young person or child, I think that would land better on some.
Sorry.
No, I'm not trying to correct or that. I'm just,
No.
you got it. I know you got it.
Okay, sure.
So
I mean,
as it
just
relates to
understood.
MST and being time limited and the research on it, has that been longitudinal? Like if Jim was a client when I was 15, my family and I, if it's time, I'm just trying to, do you know what happened to Jim 5-7 years later? Like, or is, just to see how long lasting that is. And there you go. You're going to have a slide for that.
All right. So
Appreciate it.
this was a study done in Missouri, again, years ago. And a little hard to understand, but these are young people who became court involved and then were given either MST or individual therapy. So again, this is how long MST lasts. This is the rate of arrest. So higher is better. Does that make sense? Higher is better, meaning you weren't arrested. And you see like MST completers, they were the least likely to be arrested. MST dropouts did better than the individual therapy completers or dropouts. So you see this is, a few months, but this is going on 5 years. So here you have like a 4 to 6 month treatment, and you can detect a difference 5 years later, okay? And you also see that the young people and their families, and it really is a family intervention, whether you completed treatment, now it was better short term, that was part of your question, Jim. How long does it last? Well, after about a year, whether you completed individual therapy or dropped out of individual therapy, the rates of arrest were about the same. Okay, and they've actually in Missouri followed this out like 25 years, but I'll show you a different study based on that same study, randomized controlled trial, same families, but now this is looking at the sibling of the young person who received MST. So now this is the sibling, and then the same with the siblings, the nearest in age sibling that received individual therapy. And then this is following them out 25 years now. So this is, again, here, this is arrest. So this is the rate of arrest. So high is worse, meaning you were arrested. Lower is better. And so you see this is individual therapy. This is MST. And you see that here, whether it's any crime, any felony, any misdemeanor, the sibling of the young person receiving MST 25 years later was less likely to have been arrested. Does that make sense?
Yeah, no, that answers the question. Thank you.
So you'd expect any parent intervention to have a sibling effect, that you would expect siblings to benefit, but MST actually did the study to look at something like this. And again, arrest is just, it's a proxy, if you'll accept that in behavioral health, we don't measure many outcomes, but it's not just that they weren't arrested, but how did they do this? I mean, I hope you'd accept that you improve family functioning through MST and through improving family functioning. This is how you reduce the rates of arrest.
And the proposition is, if I'm not arrested, then it's likely other outcomes are better as well.
Right. And there are other studies of MST looking at that.
Right.
Using scales, mental health systems.
So one of the criticisms of evidence-based practices is many of them have been quote unquote normed or based off white middle-class families. Can you say what we know about MST and serving youth of color, families of color?
And the next slide.
There you go. All right,
Yeah.
I'll put mute back on.
again, I know, oh wait, I still have time, I guess. Is that right?
You
Okay.
have till 2. Yeah, you're good.
Okay, great. That's right. I thought it was supposed to be. All right. So, I mean, there are some unfortunate things because of court. Oh, I was going to put it in another slide, but I think people are aware that, again, using the two of the systems that we've been talking about, child welfare and juvenile legal, both of those, you know, there are disparities there, right? I mean, Black children and Native American Indian children are much more likely to be removed from home, and they're much more likely to be arrested, incarcerated, you know, sentenced to longer sentences. So there are inequities, right? And terrible things, but as a result, MST has I guess I have a slide on this, but MST has worked a lot with kids from these groups, right? That since there are more kids, Black kids who are arrested, then there are more Black kids who have been treated by MST. So let's talk about some of what MST seeks to do. So first, we try to employ therapists from the communities being served, right? So youth and families, young people and families, you know, they're more comfortable working with people who look and talk like them. And so, you know, that's what we try to do, hire people from those communities. So it promotes engagement, it advances diversity, and we provide a lot of training, like I said, so it provides a career pathway. So for instance, in Melbourne, we hired a young woman who was Indigenous, and she wasn't qualified to even be a therapist. She had to be like a crisis caseworker, but because we provide a lot of training, and she had a voracious appetite for learning, she advanced to therapist, and in less than 4 years, she became the team supervisor, which was very quick, you know, and she didn't qualify in part to be a therapist because of, you know, educational inequities. And kudos to her. I mean, really, it all goes to her for being internally motivated. Again, just being very open to learning, supervision, training, you know, had no problem recording herself, sought feedback. But, you know, here she had an opportunity to become a supervisor. And this is, you know, again, when I know the people in this audience are aware that I mean, I benefited from my degrees as much as anyone, but really, we shouldn't be so focused on degrees, right? I mean, people can have different educational attainments, and that doesn't mean they're going to be a good therapist. So like that's one example. Actually, Jim mentioned Odessa Brown. You know, we changed the way UW Medical Center hired. You know that if you hire people in the community, you're going to have people that have a hard time passing a background check. You know, if you're going to work with court-enrolled youth and you want people in the community, you know, and again, this was years ago, but some of the folks we wanted to hire had a hard time, and we, you know, talked to the university about not using best practices in hiring, you know, so not like making the background check like disqualifying, giving people a chance to explain, and you know, and giving them second chances. And if you work with this population, I mean, you believe in second, third, and fourth chances. Here's some other information. I mean, this is just something in Australia. The Aboriginal and Torres Strait Islanders, those are the Indigenous youth. These are the non-Indigenous youth. You can see that like the outcomes were just as good, if not better. Looking at functional outcomes like being at home, going to school or working, or not being arrested. Just some other information. So this adherence measure, like I talked about, if MST, I skipped it, but there are 500 MST teams around the world. It's in 34 states. It's in 14 other countries. There are about 6 states with like nearly statewide programs, meaning like almost anywhere in Hawaii, Ohio, North Carolina, I'm leaving out some states, Pennsylvania, almost anywhere in the Netherlands, New Zealand, you can get MST, Sweden. So based on that, there's been a lot of research on MST, even looking at here, like a caregiver, the parent, therapist, ethnic similarity. MST showed that if there was a similarity in ethnicity, both self-identified, both the parent like identifying and the therapist identifying, that there was increased adherence and improved outcomes. Again, like I was saying, because there's so many African-American youth that are court involved, there's a large research base showing that MST is effective for African-American youth and families. And then this was one study looking in Los Angeles County. Hispanic youth receiving MST showed significantly more positive juvenile legal outcomes. And like I was saying before, if you emphasize the parent and youth voice and choice and family culture, and you attend to cultural differences, then you should be a more culturally attuned therapist. So like that data I showed from Australia, yeah, we had a crisis caseworker that was Indigenous. She was the only one, but otherwise there was no real training. I mean, she probably chimed in, but I mean, just by being attentive and listening to what the family wants, what the young person wants, that's what's going to get you to interventions that are culturally acceptable to the youth and family. Yeah, and the youth and family may have different ideas about culture too. I think those were most, I mean, I have other stuff on MST, but I think, I don't know if people have any questions about it. It's hard to implement. That's probably why it's not used more in Washington State, that there are high levels of accountability. Again, I've been involved in, mentioned Troopin, mild loss. We've been involved with disseminations to other states and countries, and we have had a harder time implementing in Washington State. Again, we could talk for a while why that is, but it's just the history of our system in the United States and accountability and oversight of different systems, including the mental health system. Other comments? All right, so just,
Terry, I'm just giving you a quick, you've got about 5 more minutes until we're done, but I'm interested in why it's not working in Washington. So we might need to have a further conversation because I don't want to spur that.
Yeah, I mean, well, I think growing up is more complicated in our country. That's the point of this slide. That even with the help of your family, of your parents, if you have that support, it's very hard and challenging, and including like sort of the cost or like in-kind support that most young people receive family support, and a lot of the kids, young people we're talking about, don't have that kind of support or don't enjoy that kind of support. Whoops. Okay. Again, maybe people know this, but just this is national data looking at unhoused young adults, and almost a third have been in foster care, nearly half have been incarcerated, and if you don't have like a GED equivalent, you are more likely to be unhoused. So I guess I want to talk about some of my work, like working at, say, Echo Glen. I'm really haunted by some of the transitions we had. So that there are some young people that, some of them, we had a number of young people that were adopted from like Eastern European orphanages, that had a lot of behavioral challenges, and like, people, I mean, I don't want to use a negative term, but just to kind of, since we're running out of time, that it's like a failed adoption. And this didn't have to be an adoption. There were other parents that it was their kid, like their biological kid, where they would go to court and say, I've tried everything for my kid. I can't manage. Can we just sentence my kid till they're 18? And then, then when they get out, they'll be on their own. And so there were a number of kids like this, young people like this, where we knew like a year ahead of time that they were going to get out, and there was nothing for them. And so like I can think of like we had someone in King County that King County has all these resources. We actually contacted the King County folks, and actually someone there, the person there who was going to help used to work at Echo Glen. Everyone liked this person, thought, yeah, she'll do her best to help our young person. And there was at the time like a home for young people with behavioral health needs. Like they were the place that was supposed to work, to house and treat, or at least provide support. Other agencies would provide the services, but they couldn't help our young person. And I talked to the person in charge of running it, and he said, "You're right. We are supposed to do this, but right now we don't have the staff. We've had a lot of crises happen, and if there's another crisis, my staff are all going to quit. We're not going to have a program anymore." I think of a kid that was involved with DDA, child welfare, and was in Echo Glen and was a state dependent and was eligible for extended foster care. And anyone here from Children's Administration or DCYF? This was really interesting. So again, I'll try to give the short version since we have a minute. They had actually, meaning Children's Administration, again, I've done stuff for them. I guess well, anyways, I'm saying them because at the time there are many reasons, but at the time I was working at Echo Glen saying, okay, here's a state dependent. She should be eligible for extended foster care. Well, they had made up a rule that said if you were incarcerated on your 18th birthday, you wouldn't qualify. And then it took a while to chase us down. Team Child, I saw someone from Team Child. I'd involved someone from Team Child, again, weeks, months ahead of time, hearing these barriers. And then I also involved Columbia Legal Services, just saying, there's a problem here. And so we actually spent extra staff to let her go out on a pass so she wouldn't be in Echo Glen on her 18th birthday. And there were still issues. It's like, and if you're familiar with the state organization chart, these are sister agencies. These are, at this point, they're all part of DCYF. They used to all be part of, both being child welfare and juvenile legal, used to be part of DSHS. And again, I'll give you the short version. It took a while to chase us down, but Columbia Legal Services was doing some work, and they had remembered. This was like months, maybe years later, saying, yeah, I remember you brought this up, Terry. We're doing this other thing with transition age youth between child welfare and DDA, the Developmental Disabilities Administration, and we're going to bring up this other issue. And so I don't know if it's finally been addressed, but it took months with these meetings to truly address it, because at the time, Children's Administration was saying, well, this isn't our rule. The legislature made this up. And again, Columbia Legal Services researched this and said, no, this is not. There was no legislation passed saying that kids in JRA are not eligible, who are state dependents are. But it took like a long time to really chase this down. So again, I'm just sharing something that I said.
Yeah, no, that happened during the, I'm proud that Mockingbird, the young people, we worked to get the first version of extended foster care passed. We got foster care to 21, and then Jim McDermott, who is our congressman, turned it into national legislation. But no, you're right. There's been a lot of challenges with the rulemaking process, which is after legislation is passed. I do think some of the things have been corrected in extended foster care, and it's been really, I think it's in as good a place as it's been, including getting rid of a lot of the eligibility requirements that the federal government required.
Right. Yeah, it's better. It could be better still. I
Yeah,
guess.
absolutely.
All right. Well, I'm sorry I've gone over. Thanks for listening to me.
Any quick questions, Sarah, you want to call the?
Do you see, I for some reason don't see, does anybody have hands up or questions? And if not, Terry, thank you so much. This was so interesting, and I feel like there could be multiple different topics that we could come back and talk about and kind of hone in on. So I just really, really appreciate you taking the time. And I know Jim and I will be reaching back out to you. But anybody else before we take a quick moment break? Just looking to see if we have any in the thing. All right, Terry, thank you so much. Feel free to stay on if you want to learn about Seattle's only sober recovery school. They're going to be the next presenters, and I'm really excited to hear about them. And since V's not here, we are going to take a couple minutes. Let's just do like a, 3 to 5 minutes, stretch your legs, slight wellness break, give everybody a break, and then we'll come back and listen to our next presenters.
Okay. Thanks.